our webinar. The webinar today is Pediatric Traumatic Brain Injury, Where Do We Go From Here? And our presenter today is Roberta DePompey, Dr. DePompey. She's an interim dean of the College of Health Professions, a distinguished professor and director of the School of Speech-Language Pathology at the University of Akron. Her major area of research and interest is in cognitive communication challenges to the individual with brain injury and the impact of brain injury on the family system. An advocate for the needs of youth with brain injuries and their families, she's on numerous national task forces and committees. She's helped to develop support groups and a community-based collaborative of agencies to problem-solve issues for this population. She's widely published and a national and international presenter. Dr. DePompey is recognized for her unique and innovative approaches to functional community inclusion. Her specialty is the impact of brain injury upon speech, language, communication, and learning. She was awarded the Sheldon Barrell, MD, Clinical Service Award by the Brain Injury Association of America in 2002. She received the Robert L. Moody Prize for Distinguished Initiatives in Brain Injury Research and Rehabilitation in 2004, was made a Fellow of the American Speech, Language, Hearing Association in 2006, and received the Legends Award from the North American Brain Injury Society in 2008. So welcome, Dr. DePompey. We're very happy to have you as a speaker today.
Well, thank you very much. I think we're going to have to take a minute for me to get the slides under my control here. Okay, and I think it's now under my control. So thank you so much for having me today. We're going to talk for about an hour about something that's very near and dear to my heart.
The broadcast is now starting. All attendees are in listen-only mode.
Got a second.
Okay, so we're all in listen mode. So
yes,
I think we're good to go. We're good to go. Okay. I was saying this is the topic, of course, which has been my life's work in research and clinicals, and I have to say that most of the things that I have learned have come from families and the children themselves. And so I'm hoping today to share a lot of information to you about where we go from here with our kids. I would like to start by saying in lots of states that I've visited, we always end up with task forces that say, well, we have to look at a needs study, and this is what's wrong, and this is the problem. And we could spend an hour looking at the problems, and if we did, over the past 25 to 30 years, we've always come up with the same conclusions. There's not enough information about the child count. We don't understand the uniqueness of the population. The federal government is certainly not supporting us with any funding to do research or provide services. If there is an agency, they're focusing on the needs of adults and not kids. And the hospital, community, and family supports are inefficient and fragmented. And while these are all true, I would really like to do something a little bit different today. When we talk about all the problems, we always end up saying, but they should. And I have to tell you that when we look at pediatric traumatic brain injury, it's a very little group of us. And actually, I don't know who they is. All I know is that they, when we're worried about kids with brain injuries, that's you and that's me. And actually, that equals we. And so I think that for years, we've gone around saying they should, when I believe that we should have been saying we could and we can. And there's actually information now that tells us we did. So that's what I want to do today. I want to take some time to share with you some of the information that we do have and look at some of the positive information that we need to share with others. We actually do know a lot more about our population. We have information about the spectrum of the injury. We know more about the developmental issues and how they impact traumatic brain injury over time. We know that there are some strategies for kids that work. And we actually have some colleagues nationally and internationally who are advocating and who are helping with this population. So let's just take a look at some of the things we do know and that are positive. First of all, thanks to the Center for Disease Control, we do have some numbers that can be extrapolated across our states. And overall, what we know is that about 1.5 million children are living with residuals of traumatic brain injury. About 435,000 are treated annually in emergency departments. And if we take that number of 1.5 million and add concussion, and we know that there's a lot of information and interest in concussion right now, especially in our athletes, we actually have another 1 to 2 million, according to the CDC, who are having brain injuries annually. So this really tells us that this is not a low incidence population, as is popularly believed, especially sometimes by our legislators. So we really do have a job in letting people know that this is not a low incidence, but actually a high incidence that we need to be concerned about. We also do know why we don't find them. We know that there's a great discrepancy between the number of children seen in emergency departments and the number of children who are actually referred to the schools for support for their learning or actually referred back into the community. So we know that emergency departments are not necessarily sending this information forward. They are informing parents, but not necessarily getting permission to notify schools or community partners who might be able to help. We also know that just in the general public, information about kids with brain injury is lacking, and so what we all believe as parents is that they're going to be okay. And so we don't have the right information in the public like we ought to. We're getting better because of the concussion laws that are being passed in most of our states. But again, that's for a very small group of individuals. And there doesn't seem to be the ability to say, you know, this concussion that happened to an athlete also happened to my child who fell out of the tree. So if I got to be worried about the one who had the concussion in the sports event, I probably need to have the same concerns about the one that fell out of the tree. That kind of public information is really not there. We also have developmental bias that believes for many years that kids just grow out of things, that there's plasticity of the brain, and we know there is some, but we also know that there are other things that happen that don't necessarily allow our kids after a traumatic brain injury to move in a positive way through their developmental stages. We also know that within 3 to 6 months, most of our kids and adolescents actually look okay. So it's a brain injury, it's not a broken leg. We can see the leg, we can't see the lack of functioning to the brain. So again, we just are not reporting these kids or being concerned about them. And then as I mentioned before, the general lack of public awareness of what traumatic brain injuries and acquired brain injuries actually mean to our kids as they're growing and wanting to learn and socially develop. We also have some very brand new information that was published, and I did at the end of the presentation, there are 2 references, Mazel and DeWitt and Rose and Abbott, which are now talking about the fact that traumatic brain injury should not be considered a single event, but a chronic issue. And they did a lot of research, mostly in the adult population, but the Rose and Abby issue is about children. And so they did a lot of work, and what they're trying to say to us is we need to consider this as a chronic illness. We need to go to our funders and advocate that this is a chronic illness. And it's based on the following findings. First of all, there is a potential for many more increased seizures. We used to say, oh, they might be having a seizure anywhere from 6 months to a year after their injury. The literature is actually telling us that seizures can develop up to 17, 18 years later. And when they do, they're more severe and there are more deaths related to the seizures than in the general population. There are also endocrine challenges to the endocrine system, especially in regard to the development of the pituitary gland. And so what we're seeing in our kids is precocious puberty. It includes what's on your screen there, early bone maturation, which means a lot of our kids actually end up with a short stature, some of them overweight, some of them underweight. Also, they're finding in females that menstruation is starting as early as age 5. And I don't know about you, but I don't know if I would want to deal with any 5-year-old girl starting in a menstrual cycle, but one with a brain injury as well. I have to say presents a lot of challenges. And so we need to be aware that these are happening. If our females are actually developing at a younger age, then they are at risk for sexual abuse. And there's also, in the literature, documented a greater risk for breast cancer. It's also documented that our males, through their pituitary gland, actually can become more aggressive. And certainly behavior-wise, we've seen that for many years, but we've really never taken it to a chronic illness consideration. What the authors are recommending is that there's a very simple medical test for functioning of the endocrine system, and that there actually is medication that may help our kids with this development and might curb some of these issues. So that's new information that I thought was interesting that you might want to know more about and certainly think about when you're dealing with families and maybe perhaps asking if the physician has actually done any of this testing. We also know more about the spectrum of the injury. And I know that autism has gone through saying they have a spectrum, and now they're saying, well, we don't have a spectrum, we just have autism. But actually in traumatic brain injury, we really do, because we really do go from mild to severe. And there have been some nice recognitions here. Certainly, the concussion work, which is making us aware in our schools and communities that these groups need to be accommodated. The recommendations, whether you look at Goya's work, Jerry Joya's work, and he says after concussion, you really need to be away from all activity for 2 weeks or more, to Chris Gies's work where he says not necessarily 2 weeks, but certainly you have to start doing nothing and gradually be reintroduced to all of your mental and physical activity. But we know there's a lot more information out there which is validated, and so we have some guidelines which to follow. The moderate injuries are being understood for the same reasons and are being perhaps better recognized in the schools and communities. And the severe injuries we know have been recognized because these are our kids who don't walk away after a few months without any physical implications. And so we do know that they are being qualified and accommodated in our school and community. However, not in the numbers that the CDC reports. Our special education at the federal level, at the last time of reporting, only reported 27,000 kids with traumatic brain injuries in our country. And you saw the statistics from the CDC at the beginning. So we still have a disconnect between kids being identified in the schools and the appropriate services being provided under that category. And so we do know with a lot more certainty that whether it's a simple or a complex injury, it still can affect lifelong learning and living. And that's, I think, becoming a lot more common knowledge. We also know that developmental issues with children and adolescents are really a big deal. And this has been said, we all try to claim this quote, and I think probably it was said hundreds of years ago, but children really are not little adults. And so we can't take adult methods or adult services and just simply superimpose that for our children. And so there are things that we know about developmental issues which do make our kids and our adolescents unique. We also know that children with traumatic brain injury grow up to be adults with traumatic brain injury. And so if we don't provide services for our kids, here's what we know about when they become adults. They are being identified in mental health systems with years of not having the support that they needed around the cognitive and behavioral issues. And so they're being diagnosed, perhaps incorrectly, with schizophrenia, bipolar, etc. And by this time, they are being diagnosed with depression. I don't know about you, but I'd be depressed if for my whole childhood, when I tried to learn, I wasn't given the right supports, and I'm now not successful as an adult. So we know and we can understand why they're in the mental health system. We also know if we've provided strategies early, they probably may not be there. We also know that there are, the CDC and other states have done penal institution surveys. That data is just beginning to come out. Depending on the state, we're finding 60 to 80% of our people who are in penal institutions have documented histories of childhood or young adult brain injuries. We also know that many of our kids, when they grow up, cannot hold a job, so we find them on welfare rolls. And they're also, because of their inability to function in society, are being seen by many of the adult social service agencies. Again, perhaps not being treated adequately or understood because the pediatric brain injury has long been forgotten and not been serviced. We also know more about the plasticity of our children. For many, many years, starting in the 1930s, there's the Kennard principle, which says that there's plasticity of the brain. It can change, it can develop. We can certainly see things emerge. And we have looked at that research, which, by the way, was done primarily on physical ability change and not on cognitive change. And we found that, indeed, some of our kids, and what we found is the older they are at the time of injury, the more chance they have that the plasticity will change and will help. But we've also found that the younger the child is at the time of their injury, in many, many cases, the outcome for lifelong living is worse. So we do need to take a look at some of the work by Chapman and others and be sure that we understand that kids are simply not going to grow out of their injuries, although some do. And of course, that's the joy of working with our kids. So, and this is work by Sandy Chapman and a group that got together in Galveston several years ago. And what we talked about there was the fact that if you look at the blue chart, what that is just a normally developing child. So we have a child who's growing up, and their performance, their language, their physical skills, their mental skills just evolve as they go to school and change over time. If we superimpose the red line, we know that we have a child who's normally developing, but who sustains an illness or an injury, which puts the child and the child's functioning into what Chapman calls the dip, and that's the severe dip that you see on your screen. What happens after that is that because the older the child is, the more previous-based learning they do have a little bit of time, which is like a little bit of a honeymoon, where they function on previous-based knowledge. Therefore, the reason for the child who's injured at 2 or 3 not to be able to function as well because they don't have that previous-based knowledge to sort of rely on. But what we find, what Chapman has been finding and Levin has been finding, is that many, not all, when they don't have additional supports, and the first circle sort of means that's where we're putting our support. Insurance companies are paying, the child is in the hospital, everybody's worried about the dip. But what we're being able to document on some of the kids, again, not all of them, is that as they grow, they don't keep up with their learning. And so if you see the red line, it goes down again. And that's what Chapman calls the stall. So that some of our kids really, because they have no basis in vocabulary, really go into a situation where they don't do well in school, they don't do well socially, and so they become the people who end up in the systems that we just talked about, mental health, penal, etc. So what we're looking at that point is insurance companies who are no longer, all the money's been spent, the support system is not there for these kids, and so we need to be concerned about that as well. Another aspect that we've learned about, again, this is Chapman and Cook work, is one of the things that's important to all of us as we grow and develop, and I think what's really nice that we've learned out about the brain recently is that even as adults into our 70s and 80s, we're still pruning and still actually learning. And so that, for me, I think that's good news as I get closer to some of those ages. But we actually do a lot of our learning through a type of learning which is called strategic learning. And it's one of the most important brain functions that we have. And so what we do is we actually, inside of our brain, and even as you're listening now, you actually are saying, this is important, I think I'll write this down, or that was interesting and maybe I'll remember it, or maybe I won't. What we know from all of the research on learning is that our brain is the most effective at abstract meaning and not at storing a lot of of lists or detail specific information. And so the important part of learning really becomes not about how much you learned, but how efficiently you were able to take out the main idea and how efficiently you're able to exclude what's irrelevant so you don't use up your storage capacity on something that's not relevant. And so we do have people, as all of us are, as learners, who actually have a bias towards actually seeing the forest instead of the trees. Verbatim details fade quickly. That's why when you learn that list of cranial nerves or the 7 ancient wonders of the ancient world, that you learned it for the test, and you kind of go now, yeah, I know I learned that, and you know, you can sort of, if we all got together, we might all be able to come up with the ancient wonders, but and we know where to look it up. But many of us don't use that information on a daily basis, so we actually abstracted it. And so one of my questions always is, so why are we asking kids to memorize lists of things for tests if we know this? But that's a topic for another day. But really, our abstracted learning is what we do. And so after a brain injury, our ability to find the main idea, summarize what we just heard, or interpret or deductively reason are very much impaired because our strategic learning skills are not as good and maybe are not developing because we're not teaching it. So the concepts around the research being done in strategic learning actually are that high-capacity individuals are just simply more efficient at learning what's supposed to be learned. And after a brain injury, we are inefficiently encoding and learning irrelevant information. And actually, people with brain injury, our kids, might actually store as much or more information in their memory. It's just the wrong information. And so we need to know that when we're working with our kids and helping them to develop learning strategies. Some of the things that we need to think about additionally, and this represents a lot of the work that I've done over the past 25 years, and that is that when we meet our children in the community, in school, at home, wherever they are after their brain injury, we become overly concerned about their behavior and not about the underlying learning processes which may well be responsible for that behavior. So I want to take you through just real quickly this discussion to try to make you think about this. When we write reports about our kids, we oftentimes write things like impaired attention. And when that transmits from the hospital to the school or to the community, people who might be wanting to work with our kids, impaired attention or memory actually means a lot of different things to a lot of different people. So what we really have to understand is, what is the behavior that makes you believe that this child has impaired attention? So in some cases, this child might be daydreaming. They might be bothering another student in the classroom. They might be speaking out and not paying attention to what's going on around them. They might be playing with items from their desk or in their room that have been sent to the room to their room to whatever, pick up the clothes, and they end up playing with something that they saw. Of course, lots of our kids do that, but it's just this kind of behavior is what makes us say, yes, I understand they have impaired attention. If we don't know those examples, then we don't know what to do about it. Actually, teachers and scoutmasters and lots of people, if you're told they're going to bother another kid, already have some strategies to work on that. So it becomes really important that we understand what kind of behaviors we might see with this child. We also need to understand that these behaviors are not punishable. These are behaviors that need support through whatever the impaired problem is. So if you've got a child with attention problems, we need to support the attention problem rather than punishing the behavior. Memory, short-term and long-term, I mean, there's all kinds of memory, but two which become very important. If it's short-term memory, it's never stored. We do that in the classroom a lot. Teachers will say, turn to page 43, do the first 5 math problems, turn them into desk, and then you can go do art. Our kids typically will do recency, which means they will do the last thing they heard. So this is the child that gets up and goes to the art table and gets in trouble because they didn't do the rest of the work that they were supposed to do before they got to the art table. There's also primacy, which means they will actually open the book to the right page, but they don't remember anything else about what they were supposed to do. So that's short-term memory. Long-term memory is information that is stored, and so we'll talk about that in a few minutes on another slide, but it actually is things in the classroom like not being able to remember what was studied for the test, or what the sequence of the day before was, and so they don't know the sequence of this day either. So those kinds of impaired attention and memory tasks, really the behavior ends up being punished rather than the support given to help this child through their inabilities. Inflexibility and impulsivity, we all kind of go through some of that. We all say to ourselves, our frontal lobe is our chief executive officer, and so we sort of say to ourselves, don't say that out loud, but after a brain injury, guess what? You say it. So if you're thinking that the person that's walking down the street really looks awful because they got the wrong clothes on, or the clothes are too short or too tight or whatever, you would think it. You might say it to your friend, but you might not say it to the person. After the brain injury, you're really going to say it to the person. And so we see kids who speak out. They interrupt with non-relevant topics. And so again, they're punished for the behavior, but they're not supported, they're not worked with to change the impulsivity or the inflexibility that they're demonstrating. We also, and this goes to long-term memory, there's inefficient retrieval of old or stored information. This child may be a poor test taker. They may recall information one day and not the next. And so again, it's assumed that this child has not learned the information, and it might not necessarily be that. They may have put the information in. They may have difficulty actually recalling it and getting it back out so that we know they've learned it. Again, inefficient processing of information. We've all been in classes where a person has spoken too fast. They've given us way too much information, and they haven't really taught us the vocabulary that we needed to understand some of the hard words that they're sharing with us. And so this actually is a rate of processing person of the communicator. Many of our kids are slow information processors. There's a lot of research that really tells us you can talk as much as you like, as fast as you like, they're still not going to get it. So this is one of the ones where you'll see kids asking for repeats of information, and you'll see scoutmasters, family members, teachers getting very upset and actually repeating the same thing the same way they said it 3 and 4 times. If the child didn't get it the first time, they're not going to get it because you repeated it exactly the same way the second time. So they're asking, they're not able to go, wait a minute, your rate and amount of complexity was too hard. But when they start in that behavior, this may be exactly what's going on. Or they're doodling on the paper and not paying attention to what you're doing. Or actually, we do have kids who bolt the classroom. And when they bolt the classroom, they get in trouble. And nobody's going, wait a minute, perhaps the information that I was trying to share with this child right now was too complex or too hard. So again, the behavior gets punished instead of supported by remediation. They also may have difficulty processing abstract information. They don't get double meanings of words, so it's really something we need to work on. And sometimes our kids have wonderful senses of humor, and we think they're funny and they do lots of great things, but that same child, because of their concrete learning and language skills, if you want to joke with them, doesn't get it. And so they take many more things that we say to them literally and concretely. And so we have to remember that sometimes our humor back to our kids doesn't work so well. They also may have difficulty, as we've talked about, with the dip in the stall, learning new information or procedures. So we might have put them on a computer and shown them how to get on one day, and the next day they really can't do it. And we say, gee, it's the same thing that I showed you yesterday. They can't learn the rules for a new game. They may only sort by shape, or they can't convert to color. And we know that a lot of kids up through ages 7 and 8 can't do that anyway. But our teenagers still will stick with only one way to sort, and they'll tell you, no, there's just no solution to the problem. They can't convert to another concept. we have ineffective problem solving. We know that our 2-year-olds do problem solve by temper tantrums or mommy, 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 can I have a cookie until, and then when we say no enough times, then we do see some that do have temper tantrums. And as parents and grandparents, we look around and we go, well, you know, too bad for them. Why aren't they controlling their child, etc. I always like to say that as a parent, I always did the right thing. I removed the child from the situation. I explained to them why they couldn't have what they were asking for or what have you. I have to tell you, as a grandparent, I sometimes just let them have the cookie and let their parents worry about it. So we do change some of our behaviors over time, but when we take a child with a brain injury who's 15 and who should be able to delay gratification, and they behave with a temper tantrum like that 2-year-old, you know, we don't necessarily say to ourselves that behavior is being precipitated by other kinds of inability to problem solve and have good judgment and delay gratification. This child may also stick to only that one solution, and they will not change their mind. So at that point in time, it makes no sense to try to talk them out of what they say is the right answer. Another time at another day, perhaps that's when we go back and do that instruction. We also have inappropriate or unconventional behaviors. And I leave the inappropriate on here because I want to be reminded to say to you, if we could please take inappropriate and take it away from behavior, our kids really, in many cases, don't know what inappropriate behavior is. I have to tell you, if you just told me right now something that what you just said is inappropriate, or what you just did, or you're exhibiting inappropriate behavior, I would have to tell you that I'm confused. Because sometimes, and I'm going to use cursing, because our kids oftentimes, especially in schools and in community activities, get punished or removed from circumstances because they were cursing. I have to suggest to you that we all use quotes, well, I don't know about all, but the majority of us, under certain circumstances, do use foul language. In fact, many of us choose to go see R-rated movies where the F word is, we already know when we're going in that that's what we're going to hear. So it's not the use of bad language, it's the use of bad language at the wrong time. And so, yes, we have school rules that say, well, the child should be punished, they have to go to the office. And what I say to you about that is, you're the big person. You can choose to ignore that language. Our kids, when they're quick to lose their temper, when you get into behavioral episodes with these kids, if we start to punish at that particular point in time, we're going to escalate the behavior. I'm not suggesting that it not be worked with. I am suggesting that it be worked with at another time, and that you not go back to it and say, you know what you did yesterday, you cussed and you did this and this was bad. No, in many cases they don't even remember what they did yesterday. They don't even know what the, quote, inappropriate action was. So working with them the next day on their social interactions or their social skills, or here are some other words that we can use when we're feeling frustrated or upset, may be the way to go. So I know that this is a controversial stance that I take, and I know that some school teachers will say, well, if that is the rule for one kid, then I have to let other kids do the same. And my answer to that is, really, you run your classroom. It's actually a dictatorship, and and you get to put the rules down. So I think that you can make it understood that there are different rules for behavior in your classroom for different kids. I know I've seen it happen, and I also know the school rules. So just a thought for you to sort of think about in the future. We also have impaired executive functioning with our kids. And as we grow up and as we become young adults and our frontal lobes actually are chief executive officers, we sort of have a self-awareness of what we do well and what we don't do so well. And we can set goals and we can evaluate those goals, and we can say, you know, don't tell that lady she's fat and she looks bad or whatever. So we can inhibit that. And we sort of all learn to do that as we grow. And by the time we're 21 to 25, we really pretty much have that under control. But our kids really need to need to have a lot more support around developing those skills. And again, when they don't do some of these things, we tend to dislike the behavior instead of saying, you know, the frontal lobe of this child oftentimes is non-functional. What is it that I need to do to help them develop self-awareness, which is accurate and will help them develop these executive functioning skills. What this does is it takes us to what we expect in our kids, and that is self-regulation. And this is work by Singer and Bashir, and they just say we are constantly evaluating, monitoring, and then behaving. So we have self-judgment, self-observation, and self-reaction. When we do all that perfectly, we end up with good self-regulation. I have to tell you, based on the underlying processes that we just went over, many of our kids with traumatic brain injuries are not going to have good self-regulation. So what happens when we write IEPs or lesson plans or treatment plans is that we often end up at the top of this triangle writing behavioral objectives so that our kids will have good self-regulation. And so what Singer and Bashir and others suggest is that we're starting at the wrong place with our IEP. We're trying to control a behavior without providing supports around communication, understanding, learning, reading, writing, and all of that executive functioning, attention, memory, organization, planning, problem solving. And so until we assess and treat and support some of those underlying concepts, we're not going to get self-regulation. Yes, we can change behavior. I can get a child to stop rocking in a chair. But unless we've taken care of the underlying process, another behavior will take its place. So we really do have to get better at understanding those behaviors and then starting to support our kids through treatment and environmental supports around them. So another thing that I think is really good is that we actually have resources. We are getting a lot more newspaper and magazine articles, and we have a lot of ways to access this information and share it with the public. We also know that there are agencies. Many of our agencies are starting to have trainings. Our schools are starting to work with teachers to have them know the information about our kids with brain injury. We have professional publications if you want to look more into the professional arena. And then certainly the state brain injury associations, certainly Iowa has an active brain injury association, and they have brochures and research resources which are very, very supportive and helpful. We have websites. I've given you some here which are updated, Brainline, supported federally, by the way, and with our tax money, and really, really a good one. The CDC websites are good. CBERT is a research group out in Oregon with some really, really good information as well. Certainly, if you're interested in concussion, the Physician's Toolkit and the Coach's Toolkit from the CDC are outstanding. The DVBIC is our military connection if you want to know more about our young people. And by the way, the average age of the veteran who returns with a brain injury is 19. So these are young people who are receiving those injuries. And Project LearnNet is done by Mark Ilbesacker, who passed away several years ago. But teachers, if we have teachers here and parents who want to know more about intervention for kids, this is a very dense website which you can spend a lot of time on and find a lot of really good information. We also know that we haven't done a lot of empirical research, but from our teachers and from our parents and from our kids themselves, we know that there are some strategies that do work with our kids. And so Chapman then says, if you look at the gold line, this is what we ought to be doing for our children. If we put supports around them, the dip won't be as bad and the stall might not occur. And so by using some of our strategies, we feel like we could maybe move our kids and support our kids forward. Some interventions that work. Under attention, we need to be able to do two things. And if we're writing an IEP, really there are two things. I'm not going to talk about academic supports because we know what those are supposed to be. But some other things under those underlying processes that really do need to show up, task analysis. We ask kids to do jobs that are simply too complex, that have too many steps to them. And that, you know, if I said to you, it's my birthday, and you decided that you were going to quickly bake me a birthday cake, how many steps do you think are really there? About 16. And so, but we don't think about that because we just go and bake the cake. And so sometimes we give assignments because we've given them to kids for a lot of long time, and they're successful assignments. But for our children with brain injury, we don't go back and take a look at that and go, gee, that's a lot more complex than what I thought. Maybe I need to break that down into more steps so that they can be successful. And that takes me to task completion. Kids with traumatic brain injuries, acquired brain injuries, must complete their job when they are doing the job. And that means they don't have to take home a lot of homework. They need to be able to do less work but be successful. If they're doing an art project, they need to complete the art project. If you're doing therapy with them and you're writing a treatment plan, they need to be able to finish it. And the way they do that is to do less steps. So I can ask you to make the bed, and my first step can be throw the pillow on the bed, throw the bedspread on, and everybody's happy. And once the child gets that done, the next step can be pull up the sheet, put the blanket on, throw the pillow on. And then after they get that, the next step can be pull up the sheet, pull up the blanket. And you understand, you can make it a more complex task, but you always assure that the child finishes it before you give them something else to do. I've seen many plans which say child will attend for 3 minutes, and then they'll be successful when they've attended for 5. I have to say to you that I have rarely seen any situations whereby any of us sit around and do that as adults. We don't say, okay, I'm going to listen to her for the next 3 minutes, and then when that timer goes off, if it's working okay, I'll do 5, and then, okay, I'll be successful if I've done 6. What you actually want the child to do is finish the job, make the job more complex as it goes along, so that they always have a successful activity. So that's kind of an intervention and that we know absolutely works. I firmly believe that in any job, whether it's a parent giving a job at home, teacher at school, scoutmaster, or whatever, that this belongs on the plan. It has to say the child gets to finish the job. If they can't do 10 problems, they get to do 5. I'm not going to go through every one of these things. I'm just providing you with methods that we've learned from individuals, our work, that do work with our kids. I will point out a nonverbal cueing system so the child name is not called every time they're not attending, but that they understand why a person is coming to their table or why they're being asked to go to the computer and do something a little different than the rest of the class is doing. And certainly getting rid of distractions in the work environment. That doesn't mean a sterile environment, but this child may need to face a blank wall or just be less in a less distracted area where they are. Interventions for memory. We have internal aids and external aids. Internal meaning that we're going to teach a strategy such as rehearsal or something like that. External aids meaning we're going to use something to help you to remember. So for internal, just a repetition, we know repetition is good. Rehearsal, if it's procedural, which means I get to actually get up and practice doing something, is good. I remember that. But rehearsal for a list of spelling words or going back to that strategic learning, simply asking a child to say it over and over and expecting that they're going to be able to keep a detailed list in their head probably is not teaching the correct strategy for these kids. Being able to categorize is incredibly important in chunking the information. And so these kinds of internal strategies are the ones that work for our kids. External strategies, if we're in school, carrying that assignment sheet is helpful. Pre-teaching vocabulary. Tomorrow you're going to learn about the heart chambers, and there are 4 of them, and these are the names of them, so that they don't hear it for the first time when everybody else is hearing. And we have a lot of research now that shows that there are computers, PDAs, iPads, smartphones that really, really are helping our kids. I will tell you that some of the smartphones and iPads are getting a little complex for all of us as well. So actually some of the old PDAs that you can actually find for like $25, which are very simple methodologies, are actually good for our kids. And the simpler the smartphone or the simpler the iPad that is actually being used with our kids, the better. But I completed a 5-year federal granted study on the use of smartphones, PDAs, and iPads. I will tell you that they work better than day planners, simple lists, anything else. Our kids, as our society, is very much into electronic devices, and we have the research, and if you're interested, you can email me. I'll send you more information about that. It is a successful method. Organization and planning, some strategies for that are written there. The only one I want to mention is that we do need a person. It does tend to work with a coach at the start and the end of a school day or a work day, or even at home. Here's what's going to happen today. Here's a sequence of events. Remember not to cuss. Whatever it is for 5 minutes that we need to go over with this individual. So coaching really does improve our organizational strategies. Also, practice organizing activities, and this can be as simple as sorting, throwing a bunch of objects on a table, and saying, let's pick out all the cosmetics and the jewelry, or all the trucks and the trains or whatever. So all of the sequencing activity we know is very, very helpful. Strategic learning, which we talked about at the beginning. Our kids simply cannot find the gist or the overall idea of a message. And so they need very much to learn to identify main ideas. So finding the first thing they have to be able to do is say, this is the topic. George Washington crossed the Delaware. And then we know that pretty much if they can find 2 to 3 supporting pieces of information, they're probably going to be successful. They might not be the A student, the A Cub Scout, or the A kid in the home, but if they've got 2 or 3 pieces of supporting information about the main idea, they're usually going to be successful enough. So we need them to be able to state the main idea. If they can't do the talking, they certainly maybe can highlight it if they're readers. Now, I've seen, again, plans that say child will use a highlighter. That really isn't what we mean. A highlighter at best is a material. You're using the highlighter to find the main idea and the supporting information. So that's what the plan needs to say. The child will find the main idea and supporting information, and if they're reading, they will highlight it. So again, that kind of planning needs to be kind of thought through maybe a little differently. If they're verbal, they can discuss main ideas with you. Or if they're not, they can demonstrate what did they learn, what did they think the general idea is. So providing those strategic learning strategies very succinctly. Direct learning in the schools is another technique that is highly supported by this population. Certainly, problem solving is important as well. It's important to know, how did I do this? When a child solves a math problem and they were correct, they need to be able to verbalize or show you the idea. There's a big number, there's a little number, I get another little number. They need to be able to verbalize or understand from you what was right about how I made my bed, so that the next time they know to do it the same way. And that becomes very, very critical. So another thing that needs to really, I believe, be on a treatment plan. I'm not going to really talk a lot about language, except to say that pragmatic language is social language. Knowing not to say to a friend, your hair looks bad. Knowing when you might whisper or use slang or some other kind of language, and when you should not do that. Knowing that teachers don't necessarily want cussing in their classroom, and many parents don't either. But I will also, I didn't point this out to you when I was talking about inappropriate behavior. If we tell these kids that that language is inappropriate and they live in a family environment that language is used perhaps in every sentence or any communication, they don't know what that means. And so again, we have to be very explicit in telling them, in this situation, when you say this word, it's not right, you should not do it. Again, you do not punish it when it happens. You work with them at another time to make that a successful interaction. When we have little children, certainly the intervention needs to be play. Children do not necessarily have to be in therapy 5 and 6 times a week. They certainly need to be directed. And parents, and there's a lot of research, some coming out of Brazil, which is excellent, which actually says parents are better therapists than therapists. When parents have the skills and the ideas provided to them, and when they want to do it, because actually some parents really need a respite and need others to help them get some of these things done. But what we tend to do is we tend to give parents jobs instead of giving them opportunities to play with the child. You know, we develop as many language skills by giving a bath to a child and learning, you know, scrub your nose and then your toes, as we do by sending a picture home and saying you have to sit down for 10 minutes and identify body parts. So finding ways to play, to develop social skills, interactions, rolling a ball, taking turns, getting one friend and going out for ice cream are the kinds of things that we really need to do. And we need to understand that our kids as preschoolers start vocational transitions. They need to learn turn-taking. They need to learn responsibility. They do need to organize and clean up their toys. That's on-the-job training for what we have to do as adults. And so those types of interventions, for me, and Ylva spent a lot of time writing about that, that's the kind of intervention that is more successful than sitting down and drilling activities with our preschoolers. And so I actually went through a lot of this pretty quickly, and so we might actually finish a few minutes early here. I just want to say that I believe that there are so many wonderful things that are going on for our kids. We do need to get more information out. Again, Iowa Brain Injuries Association has really good information, as do some of the websites that I cited for you. But I really have to say that the pictures that are in front of you are the reason that I do what I do. Parents and kids have the best opportunity to change and grow. And our families have taught us so much, and I recognize and want to acknowledge that we would not be where we are in this field if parents haven't given us the opportunity to do research with their kids, to learn about their families, to find out the strategies that work. And so I have a great debt that I feel like I need to acknowledge for our parents. And finally, the last slide, I just want to say to all of you who are listening, we actually, is you and me, we have a very small group of people who have good knowledge about our kids. And we need to advocate, whether it's with our legislators, our school districts, family members and friends. We are the people that can have the information, can make a difference, can support our kids as they're learning the correct kinds of, as they're being mentored through some of those underlying processes that we need to be concerned about, and not punishing these behaviors quite so much. So we know that these are things that we can do for our kids that will be successful. And those are the outcomes that we want for our children. And that is the future for our kids and our adolescents. So we need to continue to share. These seminars are wonderful. They provide lots of information to lots of people. It's archived, which means if there was one thing that you learned today that you'd like to share with others, there's lots of ways to do that. And that we really are the people. We can't rely on the federal government or the state government. We're the ones that have to stand up and learn about what we can do to support our kids so that we don't find them as adults in some of the agencies that we really don't want them to be with. So hopefully you're motivated. You were to be on this seminar to begin with, so thank you for spending some time with me. I appreciate that. We do have, if you have sent any questions in, I have been told that if there are things that need to be answered, they will email those to me. I will answer you. And so thank you so much, and I really hope that there's been at least one thing that you've heard that you will be able to take and use in the future with our kids.
Right. Thank you, Dr. DePompe. We appreciate you taking the time today to share with us more about working with kids with brain injury. I'd like to remind the group that we have in our next webinar on January 30th. The presenter is Nova Adams. She works at the Madonna Rehabilitational Hospital out of Lincoln, Nebraska, and we'll be discussing transitions for students following brain injury. Again, that's on January the 30th from 3:45 to 4:45. So thank you all for being on today, and hope to see you at the next one.